Welcome to Omega Matters, where we talk all things Omegas. I'm Christina Jackson. This is my dad, Bill Harris, and today we're welcoming Dr. Raymond Kwong, Director of the Cardiac Magnetic Resonance Imaging, or MRI, Center at the Brigham and Women's Hospital, and he's an Associate Professor of Medicine at Harvard Medical School. Dr. Kwong is most interested in studying the heart and how it remodels itself or heals itself after a heart attack and how omega-3s play into that process. So welcome, Dr. Kwong, and thank you so much for talking with us today.
Thanks so much, Christina and Bill. It's so nice to see both of you.
Yeah.
So this is an area that I've been interested in for many years in the peri-infarct or acute coronary syndrome period, when the patients are going through a very high risk of their future outcome. The reason I'm very interested in this is that we've had very effective therapies for now 20 years in revascularizing the heart, in stabilizing the heart muscle, preventing further, for example, preventing arrhythmias. And I think medical therapy has come along very nicely. And then heart attack survivors now enjoy overall much improved event-free survival in the few years after the MI. In terms of the short term, the mortality has dramatically reduced, primarily because of better intervention. We have nationwide, there is a very high availability for 24-hour cath lab, urgent intervention, primary angioplasty or stenting of the acute vessel. So mortality is improved. However, the chance of having heart failure related to a substantial injury, that actually has not changed much at all in the last 30 years. And indeed, with better patient survival overall in the short term, patients ended up living with heart failure. In the 1 year heart failure incidence after a heart attack has not changed. If anything, it's actually probably going up. So one of the issue is that we don't have a very safe and specific therapy to suppress to improve the heart muscle from salvaging the heart muscle, the initially injured heart muscle, the inflamed heart muscle. We don't have a really good and safe and effective treatment to suppress inflammation and promote healing of the heart muscle. Now, a few years ago, there is the COCA trial, which I should mention, is to use colchicine, and that was actually very promising results. So, but there is still a very limited panel of medications that we have available to remodel the heart, bring the injured heart muscle back to a normal state, suppress the inflammation, the prolonged inflammation. The initial inflammation is crucial for tissue healing, but a prolonged inflammation or inability to remodel, to reconstruct the heart muscle actually lead to heart failure. So I think that's something that I've been interested in, and omega-3 fatty acids certainly is one class of the different formulation is certainly one class of medications that seem to be promising in terms of anti-inflammatory effects, but also anti-arrhythmic effects and a whole host of other benefits to the heart muscle. So I was interested, and I get to collaborate with Bill on our several studies. The main one is a randomized control trial that we recruited in Boston, 3 major teaching hospitals. We recruited 358 patients over a 2-year period, and then we followed them up for a few years to look at how the heart changed. So we recruited.
Ray, can I stop you right there?
Right.
I think the word remodel probably doesn't make a lot of sense to layman.
Yeah.
What do you mean by the heart remodel?
Yeah, that's a great question. Remodel is the way. So if you look at the literature, there are several different ways to look at the heart structure, and there are different definitions. So the way is the heart, the left ventricle, the shape and the function, how it changes over time after a injury or an acute event. It could be a heart attack, could be a myocarditis, and it's a general term to look at how the heart restores the structure and its function, how it restores the energy of the heart so that it can pump blood effectively. So
Okay.
remodel is there are positive remodel. There's also negative remodel. The negative remodel tend to be what we mean by the heart being dilated and impaired in systolic function in the heart in a way it pumps blood is impaired, and that's so-called adverse remodeling. And there are different definitions in the literature about how to define like 10% reduction in EF or 15% increase in the size of the left ventricle. There are different definitions.
And this happens how long after you have a heart attack? How long does this take?
That's a great question. So it happens in general. The heart has initial damage, but it can continue the first 6 months in the literature that depending on the different types of injury, myocarditis or infarct. But let's say for the argument for acute infarction, a substantial heart attack can take up to 6 months to improve, to finalize how the heart will end up settling in terms of dilatation and function. And
how do you measure that?
Yeah, so that's a great question. So there are many ways of measuring the structure and the function. Historically, the most available tool is by echocardiography, ultrasound of the heart. In the last two decades or so, the improving technology using cardiac magnetic resonance, which is more precise, which is a three-dimensional technique that make no geometric assumption of the heart, is more accurate. So there has been a lot of studies and interest in using cardiac magnetic resonance, which is a non-invasive, no radiation technique to quantify the heart size and function.
Okay.
And they can also look at the damage of the heart. That's another unique thing about cardiac MRI is it can look at the infarct size and look at the fibrosis, which is the sort of the little bit of scarring in the area that is outside of the damage, outside of the heart attack. So all these benefits make cardiac MRI very attractive in studying remodeling.
Yeah. Okay, great. That brings us around to then the study you were starting to talk about, Omega-3. It was called Omega-3 Remodel, or vice versa.
Omega Remodel. Omega Remodel
Remodel
is the main. We'll call it a parent study, and then we studied a little further about the patient's effects in certain subgroups and certain conditions, such as genotypes. So we study a few other and publish a few other papers from the original data set.
Mm-hmm. Okay, so I'm gonna tell the details of what that study was, so so people can go find it. So the first paper we're going to talk about is the first author is Babak Haidari. I don't know if I'm saying that correctly. Published in Circulation in 2016, and the title is Effect of Omega-3 Acid Ethyl Esters on Left Ventricular Remodeling After Acute Myocardial Infarction. So you started to give us rationale, study design, findings. So just give us kind of the overall basics. And then we want to talk about why you think this might be happening, the mechanisms.
Right. So it was a very exciting study to us. This is about 10 years ago now, but we felt that is, we had such a strong need for a therapy to suppress in the acute phase in healing the heart, improving the heart muscle. So the vessel has been, the culprit blood vessel that caused a heart attack has been opened up in 98% of all the patients, basically. But can we, during this 6 months period, can we treat with high dose of omega-3 fatty acid and make the heart stronger? And so the patient has a lower likelihood of ending up with heart failure. So we gave the medications divided patients into two randomized groups. One group got 4 grams of Lavasa, which is a combination of EPA and DHA, about 50-50, about 1-to-1 proportion. The other group got the standard, get the placebo. Both groups get as much as possible guideline-directed medical therapy, meaning that they get the usual as prescribed at the time of what the cardiology community considered to be the must-have medication. So both groups get exactly all the other medications, beta blocker, ACE inhibitors, as they needed, aspirin at the time, and other medications to prevent them from having further heart attacks. So what we did was we looked at the heart structure at the time when they started on the on the drug, which is omega-3 fatty acid or placebo, at around 2 weeks, 2 to 4 weeks time. And then we continued the treatment for about 6 months. And at the end of the 6 months, we brought the patient back. We repeat the cardiac magnetic resonance. And also we collected blood sample and assess how they did overall. And we found that the group that was treated with omega-3 fatty acid, I would call them the Omega group, the Omega group performed substantially better on the MRI. The heart was able to pump better. It will pump down. So the heart pump down to a smaller volume is a good thing. So we adjusted, we looked at how much it pumps down, adjusting to the size of the patient, so-called ESVI, end systolic volume index, which is the reason we chose that. That's a very consistent and marker to look at remodeling, how the heart can pump down, adjusting to the patient's body size. We also look at the area of the size of the injury, which is the infarct size. We'll also look at the area that is outside of the injury, which is the fibrosis. Why is it important? Because it's well known that if the heart did not remodel well, if we did not treat properly, if there's a substantial heart attack, the remote area, the heart muscle that is away from the heart attack will form fibrosis. And that's a bad thing because the forming of fibrosis in the remote area triggers arrhythmia and heart failure over time. So we look at these three markers. We actually did not anticipate the infarct size to change much because that was determined by the primary event. Once it's injured, is injured. We're mostly interested in how the heart can pump down, because the rest of the muscle, if it does not fibrose, it's able to pump down and the patient will do better. And suffice to say, it was exciting for us to see. We analyzed the results in a double-blinded fashion, meaning the doctors and the patients do not know what the patients and the doctors do. Both of them do not know what the patients was taking. And when we measured them, we also did not know what treatment the patient was assigned to. And at 6 months, the heart function, the ESVI, was substantially better or smaller in the Omega group, and the fibrosis area was borderline, was significant, improved in the remote myocardium. There was less fibrosis, so that the whole picture fit together very well. And then we also look at the inflammatory markers. We wanted to know, why is that the case? What caused these benefits? We look at the inflammatory markers that are very crucial to the survival of patients. Some of them are the not so surprising one. The triglycerides level has gone down a lot because omega-3 fatty acid does treat that. But also, it was exciting to know that some of the more survival-related markers, such as ST2, which is a marker of remodeling and fibrosis, was substantially driven down in the Omega group. So we're very excited. The absorption of the omega fatty acids in this period by the patients were about 2.5 times increase. So that's which was exciting to us because we were also concerned that what if the patients who are on the placebo arm just go out and start changing the diet and consume a lot of over-the-counter omega-3 fatty acid because they're interested in the idea. It turned out to be not the case. It turned out that the treatment provided substantial increase. So that was actually the result because of the consistent and several lines of evidence, all pointing to the same thing. It was published in Circulation, and we received a good amount of support to the results.
Yeah. So you mentioned you didn't start the omega-3 till 2 to 4 weeks after the heart attack, right? Why was that?
That's a good question. We wanted to start earlier. At the time, this is back in more than 13, 14 years ago now, when we started the trial. There were some concern at the time that patients were getting a lot of these very powerful anti-aspirin, so-called the antiplatelet medications, and they were getting very high dose because putting in a stent is a standard therapy. Some of these stents are drug-eluting stents, and that means that they have to be taking the super aspirins. At the time, they were taking both of them. Now, and there was a concern that some patients may even need to have a blood thinner for other reasons, such as atrial fibrillation. And that combination and combining with omega-3 fatty acids, some clinicians were concerned that there is some histologic evidence from animal model that the clotting time of animals who were taking high dose omega-3 fatty acids were prolonged, and patient may have increased likelihood of bleeds. So we were strongly discouraged, and ILB made it very difficult for us to give this amount of high dose omega-3 fatty acid. At the time was considered to be novel, but also so a boldly new change in direction in giving such a high dose.
Yeah.
It turned out that when we actually analyzed our data years later, there was no excess increased bleeding at all in any of the patients treated with omega-3 fatty acid. So, so unfortunately, that means our trial started at 2 to 4 weeks. Now, you brought in a good point. Had we treated earlier, within the first few days with high dose, I personally believe that there was a very good chance that would have made even a stronger impact, a stronger remodeling, and maybe even stronger benefits to those who took the high dose, because the first 2 weeks, a lot of the remodeling already had settled in, already had happened. So so that will be for something that we should address in the future trial.
Yeah, yeah.
Yeah, that's so interesting that so when somebody's on, they're on standard of care then they're fully basically aren't clotting, adding something, it seems like you don't even have anywhere to go as far as being able to clot less than when you're already on these pharmacological drugs. And like the omega-3s do have it does extend bleeding time without having anything else on board. So I just think it's interesting that keeps coming up of like, they think it's going to add on top of the drugs as far as the bleeding goes.
Yeah, that goes to the same. It goes, based on my experience, clinicians tend to be much more conservative when it comes to a clinical trial. When it comes to treating clinical patients, they're willing to take on a new therapy when there's an indication, when the patients, especially those who are sick, they were willing to take on any risk. When it comes to a clinical trial, the patient is otherwise seemingly doing okay. Treating, they will be wary of every little thing, every little concern that is in the literature. What if this caused an issue to this patient that, so they tend to be more protective, which I can understand. But I think that over time, I think that's less of a concern. More there. For example, locally, I can say that with the results of Omega Remodel, and also in a great extent, the results are reduced, being so positive. Clinicians are adapting to the idea that this is something, the benefit is certainly outweighs any increased risk of bleeding. And I personally don't think there is an increased risk of bleeding at all, given the current evidence of omega usage.
Yeah.
Great.
Yeah, that's just a fantastic study. And especially when all of the different endpoints that you measure all point to the same direction, in conjunction with having the proof that you had good compliance, you had higher blood levels on that group. It's just a really tight story. It's really nice. And so you said you've done a lot of secondary analysis on this study, and the paper that we wanted to look at was just published in 2024, January 2024. It's entitled Effect of 6 Months Treatment with Omega-3 Acid Ethyl Esters on Long-Term Outcomes After Acute Myocardial Infarction, the Omega Remodel Randomized Clinical Trial. This first author is Bernard, and it is published in the International Journal of Cardiology. So can you set this paper up and tell us why you decided to do this analysis?
Yeah. That's a great question, Christina. So it's always been our plan It's always been from our plan to understand the clinical outcome, because understanding remodeling is very useful. But as from a mechanistic standpoint, we know what the heart is doing. It's very believable that that's a very good marker of future outcome. In fact, in the post-MRI period, the single most important marker to determine the patient's outcome is remodeling. So we already addressed that. We know we conquer that. There is a good mechanism, but that the heart is actually feeling better, doing better, and is at a mechanistic level. The omega-3 fatty acid is beneficial because of the different lines of evidence. But we still want to know. We still want to know what is the actual event that happened to the patient. Now, Omega Remodel was a small study. It's only 358 patients. And these days, as I mentioned, patients overall is a good thing that the overall risk of a bad outcome after a heart attack it's reduced a lot compared to a few decades ago. In the first year, which is the higher risk period, even that high risk period is driven down to about 5%, 5 to 7% of bad outcome what happened to patients even with substantial heart attack. So with that backdrop, that means that to understand the outcome of these patients, of this small number of patients split into two groups, we have to follow them longer. We have to let time figure out. We have to have further understanding, because some patients are not going to develop heart failure until years later. So we follow them for about 8 years. And that's why it took so long for us to publish this paper. We follow them every year. In fact, most of them we follow every 6 months. And then we still give advice about how they're doing and so forth. Many patients were very appreciative and stay in the study. And we follow as much as possible everyone after 8 years, and we have enough numbers of good events, but also not very good events. We need to have enough proportion of patients with, unfortunately, bad events before we can answer the question whether omega-3 fatty acid has an impact. And we actually observed that there was a significant difference. The remodeling, which is in line with the remodeling, those patients who actually was able to increase their omega-3 acid or also called O3 index level in the blood sample, if they were initially able to change that, they do a lot better clinically down the road, meaning that they have less chance of dying from a heart-related disease, a heart-related cause, or coming into the hospital with clinical heart failure. So that was significant, but only we observed that, only seen that in those patients who was able to show that they absorb a lot. They were able to change a lot. Now, they could either have a very low omega-3 fatty acid index to start with, but increase substantially, but they have to increase by 5%. Now, that has important implication, because I think that it's true that in patients in this part of the world, they tend to have, in North America, they tend to have a relatively low omega-3 index to start with. The average was about 3%, which is substantially lower in some other countries, such as Japan or Korea. But so 3 to 4% is fairly low, but if they can mount it to about by 5 points, that's when those patients tend to perform a lot better down the road. So this is important because this is actually a objective assessment of what they did clinically, as opposed to an indirect assessment of what's happening at the heart level. So I think that we need a larger study, because this is, again, it's a small study. We observed that overall, the assignment did not change, did not seem to be a direct factor in driving better outcome, but it's the patients who have mounted a good omega-3 index response. Have we studied a lot larger number of patients? Maybe we will have seen a bigger response. Had we treated them early and we will have seen a bigger response? is beyond the context of this study, but it will be interesting to, with these sort of background evidence, to study these trials in the future.
So not everybody who got the omega-3s got an increase in their, a big enough increase in their omega-3. What percent, do you remember what percent of those that were given randomized to omega-3 actually had that delta of 5%? You know, was like half of them, or?
No, not that high. I don't remember an exact number, but I think it was in the order of about 15-20% mounted. Yeah, mounted that degree, and those people tend to do a lot.
Were they more compliant, or do you know?
I think there is a mixed bag. So there, some of them were, some of them was because their level was very low to start with, and they took the omega-3 fatty acid. They can rise it. There's also a observation that we're still analyzing, that it seems that if anyone can get to 8%, no matter what you start with, but if you can, you know, even whether you're starting with low or higher omega-3 fatty acid, if you can get to 8 or 8.5, that tends to be very protective.
Okay, no matter where you started. Yeah.
No matter where you start. So sort of that's sort of in keeping with some of the epidemiologic data from Japan that show that, you know, if you have that degree, that confers a lot higher protection towards cardiovascular disease. In this case, bad outcome from a heart attack. Yeah. So so that's a great segue looking into another paper that we look at, that we believe that the genetic factors, the genetic makeup of a patient could be related to how well they can mount that response, how well they can mount that. Although this is still under investigation, our data set is small. Certainly, you know, it's a pilot evidence only that we can conclude on how the vast variability of genotypes, genetic makeup of patients can have. But we observe, we pick one of the very promising gene in the metabolism of fatty acid dismutase, which is the enzyme that controls how fatty acid can be metabolized. And we found that there's one gene, although I'm sure there are lots of many other genes, but we just picked this one gene because it was in literature. It has been reported to have an association, how we can metabolize the initial substrates into effective omega-3 fatty acid. We found that there are patients with this gene that is known to have a deficiency in endogenous metabolism. Those patients benefited a lot more from taking exogenous omega-3 fatty acid, and they benefited, and they can get up to 8%, 9%. Otherwise, they need it. We found that has an association with remodeling. That was published in another paper. But again, that was only pilot data. How we can understand the impacts of genetic variation, of course, will take a much larger clinical sample of patients.
Wow. So just to summarize, you say the fatty acid desaturase gene, FADS.
Yeah.
So if you had a mutation, if you had a less common variant, a less effective enzyme, I guess, those people responded better to the same dose of omega-3 than people had a normal fats.
Right.
Interesting.
Yeah.
So they have lower omega-3 levels to begin with?
Yeah, so they do have a lower, some patients have a lower, some patients with the subtype of that gene. That was actually published in Fujikura et al. in our publication record, that we found that a subtype of that gene, they tend to have a lower baseline, and they tend to, and they can, by taking exogenous omega-3 fatty acid, then the remodeling was suppressed, was better. But compared to people who have a higher level on another subtype of that gene, the benefit is less. But the patients who benefit the most are the people who have a very low level, and that subtype of the RS3235 gene, that they tend to also relate it to the inflammatory markers as well. We observe results, we observe consistent benefit, not only in the end systolic volume index, which is how the heart can contract down, but also in the remote myocardium as well. the fibrosis of the heart muscle, so that the results are in line and consistent with each other.
Wow.
So
this is a very novel study. I don't think I've seen hardly anybody who has used the change in the omega-3 index as the primary indicator of whether someone had benefit or not.
that's exactly right. That we're excited too, because that also begs the question, oh, should we have genotype these people and tailor who would benefit the most? Now, there will be a tough sell because omega-3 fatty acid index is so safe and so effective. And overall, you may as well, some people argue that why don't you just treat everyone? And it's such a safe medication and literally no side effects. But there's still a cost. One can argue that would it be effective, sort of have a personalized approach? You genotype someone, and then you treat with high dose, and then select those people who can benefit the most to treat. That's an intriguing question.
But right. I mean, it makes more sense. I mean, a good number of the people that you gave a high dose to did not get a big change.
Exactly.
But if you'd given them a higher dose yet, it might have, I mean, it basically titrating up to an omega-3 index of 8.
Yeah.
Regardless of what the dose is, to get there would be a great way to go.
Yeah, the personalized approach is very intriguing, and I would we're interested in studying further. Omega-3 fatty acid is a very safely tolerated drug. In general, that sort of personalized approach is more important in drug or treatment that are unsafe, that has a higher risk profile, procedurally, or but in this case, I think it's still relevant.
Right. How has it changed your practice?
So that has not, the genotype first approach has not translated into clinical practice yet because of logistic challenges. Because you have to genotype them quickly and then make a decision very quickly before you treat. But I would say that I don't have, right now, such genotype testing is not available readily. There are some companies that can do that, but the turnaround time will slow me from treating the patient. So I just go ahead and treat patients when I think that the patient can benefit.
Yeah. Do you measure the omega-3 index in your patients?
Right now, my hospital does not run that blood test. So it would involve some specialized samples sent to specialized company like yours, and the logistic issue is a little bit challenging, and also the cost of the blood test is certainly something that we have to improve. But I just, because I know that the patient can benefit, I just go ahead and treat the patient.
And again, roughly 4 grams.
4 grams. Right now, now there are some. I think FDA allow it to give even higher, to 6 grams now. But I've been giving patients 4 grams because I know that that was something that I was very comfortable with using.
Great.
Yeah, and that change, that 5% change was within the study. It was that 6 months of dosing, and you followed them for 8 years out. Did you get any other blood sampling from those visits, or were you just like to be able to look at what their blood levels were as they?
That would be interesting. It would have been interesting to know did this patient did it stay up? Did it change their dietary behavior, or did it? But because of cost issues from that small NIH funded study, we were not able to bring them back for a third blood sample beyond the 6 months. So we only rely on following them, talking to them over phone about how they're doing. We do follow them with validated risk scores about how their behavior, how they're feeling, and the angina and scores and so forth. But blood test wise, we only had the 2 samples, the 2 to 4 weeks and the 6 months.
Did you ask them in this long follow-up? Do you ask them if they are taking fish oil supplements?
I have to go back and look at that. I don't think we did. I think we were focusing on clinical outcomes only.
And you reported a benefit in total mortality, right?
Yeah.
In your most recent
cardiovascular mortality, cardiovascular, right?
Okay, and then did you look at heart failure per se? Developing heart failure?
Yeah, so all patients we assessed actually not only heart failure, but the outcome we also included if they have a serious arrhythmias as well. So,
Oh.
but if you look at the patients who had bad outcome, they're dominated by death or heart failure presentation. Some patients we also counted arrhythmia. So in totality, the total number of events included some bad arrhythmia. We're not counting the minor extra beats. We're counting the serious arrhythmia. Some patients ended up with an ICD. If the ICD fire, if the ICD of the patient had serious arrhythmia, we counted those as well. But the majority of outcome were heart failure, hospitalization. We're talking about heart failure presenting to a doctor's office and necessitated increase in medications or hospitalization coming in the hospital.
Yeah, yeah.
That's great.
Great stuff. Great stuff.
Yeah. Yeah. So I think that, I mean, I think we've covered a lot of what we wanted to, just hearing how you run these studies and how it actually is affecting your practice, or it's so great to get clinicians on who are also in the research field. Because we feel like that's such a big block right now, and they make free.
The exciting thing is that, as you mentioned, Christina, that this is unique in the fact that it is one of the few medications that we have, one of the few things we have in our ammunition to suppress inflammation. Another thing is that it is not unique to acute coronary syndrome or heart attacks per se. It can be applied to, I believe that this can apply to other types of injury. A patient with myocarditis, which is very common, affecting even younger patients, or other types of myocardial injury. I think that, whether that would and the fact that omega-3 fatty acid is distinctly different from other more, it's sort of in some way is non-specific in terms of the inflammation, but it also has substrates that can promote healing, promote reconstruction of tissue building blocks, which is not the case in some of the more very potent inflammation. Inflammation is crucial for a heart to heal. So inflammation is good. It's this later prolonged type of inflammation that will generate fibrosis. That is not good. So we need to have a drug that can balance both acts and be able to shut down the harmful prolonged inflammation, but promote tissue healing. And I think this distinctly make omega-3 fatty acid stand out compared to other drugs, such as we have tested steroids, we have tested cyclosporin. None of them work. Now, colchicine is promising too, but so is omega-3 fatty acid. So I think this is we're just really scratching the surface in how this medication can benefit cardiovascular patients during the acute window. What I noticed was that it takes the acuteness of a acute window and treating it with high dose during an acute window that change the outcome of the patients.
Yeah, that's a great way to end.
Yeah, I think that said it all.
Soundbite there. I love it.
Yeah. Thank you so much. This was fascinating. And also just thank you for explaining the heart so well. It's just fascinating to hear it from such an expert. And and we'll be watching you and hoping to see some more papers coming out.
Thank you so much. Thanks for the time and the opportunity to discuss our research, and it's a very exciting time.
Thank you. Thanks, Raymond.